You can go ahead and get started, Dr.
Okay. Can everyone hear me? Should I just stand? Let's see. Can anyone hear me okay?
Yes.
Everyone hear me okay. So welcome to the Cancer Support Community Workshop on bladder cancer. I'm Dr. Katebian. I'm one of the urologists at Adventist Health Simi Valley, and I wanted to just kind of run through some things with you guys. If you guys have questions or things, you can enter them in the chat. I think you can even raise your hands on the Zoom. And then, yeah, we can start.
And then just one other thing, there is a survey in front of you, and for those that are joining online, the survey is in the chat. It would be really helpful if you could fill that out, and then feel free to take notes, and I'll leave it up to Dr. Katebian now.
Okay, perfect. So this is me. I'm Dr. Katebian. Like I said, I work at Simi Valley Adventist. I grew up in Thousand Oaks. I actually went to Thousand Oaks High School. I did my training at USC Medical School, and then I did my residency at University of Chicago, but now I'm here back in Ventura County.
Where in Chicago?
Where in Chicago? University of Chicago, so it's like South Side Chicago.
Wow.
Yeah, south, very south. So the agenda today, so I'm gonna give you guys like a rundown on bladder cancer staging and treatment. And then you can do next. You can just keep pressing until the slides fill. We're gonna talk about decisions you guys can make, how to stay healthy through this entire process, and what to expect after diagnosis. So just some rudimentary things. So bladder cancer is when cancer cells arise, typically from the lining of the bladder cells. The most common cause or type of bladder cancer is called urothelial, meaning it comes from the lining of the cells. Once cells start to replicate, they form some small tumors, and then as a result of that, typically the most common presenting symptom is either blood in the urine you can see or on a diagnostic test. You can go next slide. So these are just some common terms you may hear or have heard. So chemotherapy typically revolves around treatment, which is used to kill cancer-related cells through stopping them in some form of cell division. Targeted therapy is a newer generation of medical therapy for bladder cancer, which usually tries to target certain cell checkpoints on bladder cancer cells. Radiation therapy is conventional radiation treatment using radio energy to kill cancer cells. Immunotherapy are also newer generations of therapy which involve sensitizing cancer cells so your own body fights them. Maintenance therapy is a term that we typically use for once someone has achieved a state where bladder cancer is not seen on imaging or on a diagnostic test, so we can keep them from recurring. We typically put them on maintenance therapy. Trimodality therapy is typically also called triplet therapy, which involves a combination of surgery, chemotherapy, and radiation. And then clinical trial is typically reserved for instances where patients want another form of treatment, but is not quite standard of care, and we're doing testing to understand the efficacy. So, we'll go next slide. Oh yeah, then cystectomy is typically surgery which involves either removing part of the bladder or the entire bladder entirely. There might be one more. Urostomy is usually the creation of a reservoir which holds urine, which then is brought to the skin and then drains into a bag. It's typically done after we remove the bladder. And then chemoradiation is the combination of providing chemotherapy which sensitizes cancer cells to radiation. And then next slide. So bladder cancer, as I'm going to explain, is kind of like it's a wide range of disease states, and in some instances you might be introduced to a lot of care members. Those can include medical and radiation oncologists. You may meet with a specialized urologic oncologist. You may also meet with wound ostomy nurses, palliative care specialists, physical therapists, even your own primary care are all going to be involved in these. You can go next slide. Dietitian also very helpful. And then social workers can help because there's going to be a lot of appointments and getting to them sometimes is challenging. Okay. So why is cancer staging necessary? So these are really good questions that patients bring to me all the time. Usually when I give them a diagnosis, they'll say, like, what stage am I? It's really important to understand what stage you are or what risk category you fall into, because bladder cancer treatment is very wide. So it can change dramatically based upon stage. And the goal of bladder cancer treatment is to prevent recurrence and progression. So it's possible that you may be staged at one time, get treatments, and then had to get restaging. Things might get better, things may get worse. So it's important to stay in check with your urologist and your care team too. We go next. Should be one more question. And then what diagnostic tests do you perform that help you understand the staging of bladder cancer? Typically they involve a couple of things. Some are just routine lab work. Others are imaging tests that look at the bladder and the kidneys as well as the organs around these areas. And then we do a lot of diagnostic cystoscopies in the office as well. So those all are helpful too. And then I think I discussed the stage does impact treatment. So let's go over some staging. So there's stage 0 and stage 1. This is included into non-muscle invasive bladder cancer. Non-muscle invasive bladder cancer is typically worked up and treated with a procedure called a transurethral resection of bladder tumor. This is when you're fully asleep, usually under general anesthetic. A urologist like myself puts this camera called a resectoscope into the bladder through your urethra, and then we resect the tumor and then send it to pathology. Generally, for non-muscle invasive bladder cancer, you will be given like a risk category, either low or high. Typically, low-risk bladder cancer is just treated with surveillance, meaning we kind of watch you with periodic cystoscopies. Intermediate and higher risk bladder cancer sometimes require therapies that are put into the bladder. They're called intravesical therapies. Chemotherapy is one of them, but we also have another medication called BCG. You can go next. We should be at BCG. BCG is actually a bacteria. It's actually like a cousin of the tuberculosis bacteria. It's kind of interesting. We don't really exactly know how it works, but there's been a lot of studies that show that if you can take this bacteria that's been produced in the lab and put it into the bladder then becomes sensitized to the bladder cancer cells and actually fights it. So BCG is considered gold standard therapy for patients that have especially high risk non-muscle invasive bladder cancer. So the goal of non-muscle invasive bladder cancer is to identify it early, provide you a treatment in the form of transurethral resection of bladder tumor, possibly chemotherapy or a BCG treatment, and then follow you for a period of time, and then ideally there's no evidence of disease. Muscle invasive starts to become a little bit more challenging, but there is still treatment for cure. We have stage 2 and stage 3. Stage 2 basically means that the bladder cancer has invaded into the muscle of the bladder wall. Stage 3 will say that it's actually starting to invade around the fat of the bladder, so it's starting to come outside of the bladder. And then we have stage 4, which is considered locally invasive or metastatic. So locally invasive meaning it's starting to invade into other structures of the pelvis, be it the prostate, the rectum, the vagina, or the uterus, or metastatic meaning it's starting, it has evidence of spread on imaging. So muscle invasive bladder cancer does have several treatment options. The gold standard is typically a form of chemotherapy that we give before or after treatment, followed by usually removal of the bladder or part of the bladder. Generally, it's the entire bladder. In some instances, we may also use immunotherapy after or before surgery, and the same goes with targeted therapy. So this is kind of the goals of not only bladder cancer, but basically all cancers that we treat as a medical specialty is to find it early, slow its spread, limit its growth, provide you symptomatic improvement, and extend your longevity. So those are all important. And then improve quality of life. So maintenance therapy I touched on. There's two settings where we typically will use it. In the non-muscle invasive setting, it's someone that has had treatment. We look back inside their bladder, there's no evidence of residual tumor, and then we will typically put them on an intravesical, meaning inside the bladder treatment schedule, where we try to put some medication to the bladder, be it chemotherapy or BCG, to prevent cancer from coming back. And then in the metastatic setting, typically we have medications or chemotherapy that are used to stop the progression or growth of bladder cancer cells. Yes?
Do they have any pill form to prevent cancer at this point?
So yeah, not to prevent cancer, but basically a lot of the immunotherapies and targeted therapies are actually pills you take. So they're not a chemotherapy in the same way you get an IV and you have side effects of chemo. These other medications still have side effects, but they're better tolerated. And then can staging and treatment options change over the time? The answer is yes. So preparing for appointments. So like what would I do if I was a patient and I needed to navigate the healthcare system? So I would come in with a lot of questions. I would bring someone who is like close to me, who can help with me to make decisions and I can talk to. I actually brought my mom today, so she would be the person I'd bring. I would take a lot of notes, and then I would raise questions on like, if I'm getting this treatment, what are the side effects? What are the potential complications? And then I would also raise like whatever concerns I would have regarding treatments, like how are they going to affect my quality of life? We can go next slide, You can kind of go open up there's a little prompts. So yeah, I think when you try to come to a doctor's visit, especially if you have a complex medical problem, this isn't even necessarily specific to this, but in general, like you should think about how, what treatments or what disease processes are going to affect my well-being, how is it going to affect my relationships with other people, how I'm going to be able to deal with work or school related to these things, and then how do I get involved in finding support within the community? And then there's also like what else could be important to you that might be affected by treatments? And then bringing all those things before the visit and having your provider address them is actually very helpful. Second opinion. So this is a story about Carl who he was diagnosed with bladder cancer. He just talks about his experience. So we can just watch this video if we'd like. I don't know if you guys can hear the sound.
You'd have to put the volume of the remote.
Oh, this?
Yeah.
It's on mute.
I think it's muted on the laptop.
How old's Carl?
Carl is, I think, in his 60s or 70s. I can also explain the story too, if you guys like. So Carl is a patient. He was diagnosed with bladder cancer. Oh, see if you can unmute it. See if that works.
I think we'll should this.
Oh, it's here. It's right here. No, it doesn't. It doesn't necessarily work.
There you go.
I think that's me talking. Can you guys hear me okay? Still? So Carl is in his it's like 60s to 70s. He was diagnosed with bladder cancer. He underwent some treatments with intravesical therapy. He had progression and needed to eventually get his bladder removed. He sought a second opinion after this with like another urologist about treatment options. Ultimately, he also needed to get chemotherapy. He talks in the video about how he developed some side effects from the chemo and how working with his oncologist as well as with his urologist, he was able to find some balance in his life so he could regain the functional capacity to do what he enjoys. So that's usually what Carl's talking about. So clinical trials. Clinical trials are, I can hear myself on this. Maybe let me see if I can turn this down. There are instances where your urologist or oncologist might refer you for a clinical trial. And the things that happen the most frequently, or when I would typically refer patients to clinical trial, is in instances where, let's say, a patient has non-muscle invasive bladder cancer, they're high risk, they've gotten multiple BCG treatments, and it's not working, the cancer is not going away. They don't necessarily want to move forward to removing the bladder entirely, so they want to pursue a middle stage. There's a lot of clinical trials that are looking at how you can treat patients that have BCG or, intravesical chemotherapy unresponsive bladder cancer. And so I would always try to ask questions to your oncology team and also your urologist about if there are any clinical trials that could be helpful for your specific situation. They're not for everybody, and not everybody can enroll. There's certain parameters that need to be met for you to enroll in a clinical trial, but I would be curious to raise them to your urologist or care team if you have questions. Okay, and then here's some challenges. So this is like a pretty common, this is like most of the patients I see. So you meet a new patient, you tell them they have a very serious diagnosis, and then you tell them they have to get this lab, this imaging test, see this doctor, get this clearance, and then you ship them on this like basically highway. And I think for a lot of patients, they identify with having a loss of control because now their life has become overrun by things related to their bladder cancer care, and they sometimes don't have the voice to say that I'm not feeling well, I have concerns, or I'm anxious. So then you go through this entire process, and then you may not be able to necessarily have someone who's on your side or necessarily like in your team that's like kind of pushing to getting all these things done, so you develop a sense of loneliness. And then no one's really also telling you what are the next steps or what happens if this treatment fails, and as a result, you're living with anxiety and uncertainty. And I can say that with anyone with bladder cancer or any chronic illness, this is very common. So, like I talked about with bladder cancer, there's many kinds of treatments depending on stage. So, side effects from treatment can include a lot of things. So this may not apply to everybody, but it can include nausea, neuropathy, fatigue, skin changes, hair loss. Some chemotherapies can cause cognitive changes. A lot of the treatments we do that are in the bladder can cause a lot of bothersome urinary symptoms. And then, of course, you may experience sexual dysfunction related to treatment or overall anxiety, and then blood in the urine, which is called hematuria, and weight loss, and loss of appetite. So, a lot of times patients will also ask me, like, what can I do personally? You know, I'm doing all the things you told me to do, like go to these appointments, get these tests, do this surgery, take this drug. But what can I do personally to help myself? Like, what can I do? And, you know, we have surveys from the Cancer Experience Registry that many people are concerned about how to eat healthier, how to live healthier while going through this entire process. I could say this, like, the number one risk factor for developing any sort of bladder cancer is a smoking history. And oftentimes, patients will continue smoking or prevent themselves from quitting while they're on bladder cancer treatments. And we have seen that patients that don't quit smoking actually do worse through treatment. Their bladder cancer might become more aggressive. They also don't heal as well from surgeries and treatments when they're smoking. So I would tell patients the best thing you can do is quit smoking. That's the number one thing. And there's lots of things we can do to help with that as well, which include having you start on nicotine replacement therapy, even seeing like addictive psychological services to help with quitting. And then generally it's also, I motivate patients to try to go back to eating like a healthy lifestyle and being as active as possible. Anything you can do to really expand your physiologic reserve so you have more energy and have more vitality is going to make you stronger when facing more aggressive treatments too. And sometimes that's raising these questions and concerns with your primary care, your urologist. Sometimes we can get you in touch with a dietitian or a physical therapist.
Question, is it more common in males or female bladder cancer?
That's interesting. So it is more common in men, even if you control for all things. Men typically smoke more, but even if you control for that, bladder cancer, for whatever reason, which we don't understand, more typically affects men.
I'm bad luck. But I never smoked, so that's
that is uncommon. That's very rare. There's other, I can touch on those too. There's also other things that can make you more prone to developing bladder cancer. Occupational exposures are a big one. Like if you're exposed to a lot of fumes and dyes, like I have patients that they were like lifelong truckers and they were around like gasoline for large periods of time. That puts them at risk. If they worked in any sort of textile industry, that also puts them at risk. Chronic catheterization. And then there's also weird things like if you had certain infections in endemic regions of the world, can also put you at risk of bladder cancer. So physical therapy, why I like it. It makes you stronger. Some patients develop symptoms related to incontinence after bladder preserving therapies, and sometimes bladder treating can help you stay drier. And then it also like feels good to be more fit. You'll feel more confident. A large percentage of patients, 42%, were concerned about just daily activities like walking around, climbing stairs, and lifting. A lot of the time, patients might even have catheters, and they're concerned about what activities they can do with and without them. And having like a trained physical therapist or even an occupational therapist to kind of work through your daily activities is very helpful for making sure you're staying active. So let's say you get to the point where your urologist or urologic oncologist states that it would be a good idea to remove the bladder. We have to put the urine somewhere, so we have to form one of these three types of diversion. They're all made with your own bowel segment. An incontinent diversion is typically also synonymous with the word urostomy. So we take a bowel segment, we create a little stoma or opening, and then we bring it to your abdominal wall, and then we have urine drain continuously into a bag. It's called incontinent because you don't have control over it, it just continuously drains into a bag. There's also other things called continent diversions. Sometimes someone will say the word Indiana pouch, that's the name of a type of continent diversion. Rather than developing a stoma that drains continuously to a bag, you have a catheterizable channel. So anytime you feel we ask you to urinate, you basically take a small catheter and then you catheterize a stoma, which is typically like a third belly button, or second belly button that you will end up draining your bladder. And then there's neobladder, which typically involves reconstructing a large reservoir, which is then connected to your native urethra. So you don't have nothing's visible from the outside, but you have, instead of having a bladder that you're born with, now you have one that's made of bowel. Neobladders are not for everybody. There's certain circumstances we would recommend not getting one. Neobladders function a little bit differently than your normal bladder. You don't sense that your bladder is full, so you have to be on a time schedule to empty your bladder. Sometimes that requires you to kind of push around the area where your bladder is. And in some instances, you may also need to catheterize yourself through your urethra to empty your neobladder. So those are things that should be talked about if you're desiring to have surgery. So having a cystectomy or removing the bladder has a lot of changes on your body. Same thing with chemotherapy and radiation. And then how you perceive yourself after surgery is also, can be sometimes a little bit nerve-wracking. So cystectomy in itself, when we remove the bladder, we have to divert the urine through bowel. The bowel, absorbs things. It absorbs urine now, so you might develop like metabolic changes. Sometimes patients feel that they don't have as much energy immediately after surgery, even for a couple months. Chemotherapy and radiation themselves can have side effects, including fatigue, nausea, changes in kidney function, hearing as well. And then body image, going through big surgeries, having catheters, having bags, now changes how you perceive yourself, which is really important to understand. The thing I can say about all these things is that like sometimes we have to choose, we don't have a decision about quality of life. Sometimes we have to choose longevity and life. And I think reminding yourself that maybe my body is changing, maybe I look different, but I'm progressing, I'm feeling, and I'm doing better. And those are things I try to remember, tell patients to remember. And then intimacy is also a big thing that changes with bladder cancer as well. And a lot of people feel nervous or even to some degree of shame when addressing these problems with their provider. I know it's sometimes hard for some people to talk about. Not all the time does even a urologist like myself always ask about it. And this is my job. So I think sometimes it's important to say that like I'm having issues with sexual function or intimacy, what can I do to improve them? And there's lots of good treatments for it too, so I'd raise those questions. And then this kind of just talks about some things we already know, and I think why a lot of us are already here is that having a new diagnosis, dealing with treatment, seeing lots of doctors causes a lot of anxiety, clinically significant depression, and then raising those things with your provider is helpful because we can help you see, get you in touch with support groups like this one, get you in touch with therapists, even find you solutions to problems that you may have thought were insurmountable as well. So they're all. So yeah, so a lot of patients, they also have concerns about how am I going to pay for all of these things. There's certainly some insurance plans that are better served for someone with a chronic condition that's seeing doctors routinely and needing lots of medications than others, and sometimes requires you to get in touch with a care coordinator to find like a better insurance plan that goes well with what you're going through. And I would just make sure you are staying in touch with your primary care or your urologist to find the best plan for you to help you out with that. So the thing about bladder cancer too, I'd like to say is that it does come back. Sometimes it does not progress, but sometimes it likes to be very annoying and comes back. As a result of this, you have a lot of visits where we have to check to see if it comes back. Lots of people have anxiety related to these appointments, which I would say is very normal. A lot of people have anxiety related to getting CT scans to see if there's recurrence or even office cystoscopies. What I would recommend for patients that have a lot of anxiety is to kind of keep a track of what's happening, take good notes at each appointment to understand what are the next steps. If things come back, what is the next step? How to prevent recurrences in the future. These are all questions that I think are important to ask. And then another term that is typically included is something called survivorship care plan, which is basically a plan that you have created upon going to multiple office visits about what are the next steps related to your care. So taking good notes, understanding what are the next steps helps prevent unnecessary anxiety too. So this is a little bit what I talked about. Take a summary of your treatments. When's your next follow-up? What screening tests you should have. And then what specialists you see. And then we have palliative care. Typically, palliative care is not curative. It's mainly just for symptom improvement. It can help improve your quality of life, and it's sometimes given in conjunction with cancer treatment. I think it's important also to discuss this with the treatment team about seeking a consult to palliative care medicine too. That's something you'd like to focus on. I think that's it. So if you guys have questions, I can help answer questions. Yes?
I do. I've been on BCG for about 3 years.
Mm-hmm.
I got over prostate cancer 10, 12 years ago, and I had a huge amount of radiation, brachytherapy. So I don't know what caused bladder cancer, but could have been that. But I'm concerned about BCG failing, and I'm interested in these Activa is one drug, and then there's this gemcitabine in a thing that's been developed by USC. Have you had any experience with those two?
Yeah, so once a patient develops something it's called BCG failure, which is defined by like you've had X amount of BCG treatments, but the cancer still comes back. You have like a lot of options. So one of the options is to consider chemotherapy, which is gemcitabine and docetaxel rather than BCG. Another one is to consider other types of targeted therapies in the bladder, like there's one called nidofaragine. Patients could also consider clinical trial. And then the last option, which some patients do consider getting, is just a bladder removed, and then diversion too.
May I suggest that TAR 200
Is that the one you're on?
No.
TAR 200?
But that's one of the ones I asked about.
Yes.
It's gemcitabine in a.
But it releases it slowly.
Yes.
Yeah. I mean, instead of,
I just
an
wondered
hour.
if my urologist had not had any experience with that. I just wondered.
Yeah, so yeah, the
you
thing
cross
is,
paths with it.
I have not crossed paths with it. So the thing about bladder cancer treatments is sometimes they can be very expensive. Even BCG itself is like very hard to find. And it can only be really allocated towards like large academic centers. So sometimes I have patients that are in these like specific circumstances like yourself, consult with like a large academic center, because not only do they have likely like newer treatments, but they also have openings for newer clinical trials too, if that's something that
Can I ask you where you got your BCG? Was it here in Ventura County?
Well, when it was in shortage here, I got it from a doctor in LA. But And then I was getting half a dose for a
Yeah.
while. And I'm concerned that it's gonna, I went on about 3 years.
Mm-hmm.
And the doctor, one of my doctors says that the longer you're on it, the better off you are.
Yeah.
The chance of failure ultimately is less. Well, of course, I'm getting older too. But I'm interested in these other two things that I read about, the gemcitabine slow release in the little snail. Oh, that's interesting to me. And I don't have any problems. I've got some other condition, a genetic condition that is just skyrocketing my expenses. So anything I would pay for BCG or anything else would be low. I'm not worried about it. I got a good drug plan, and apparently they like me.
So I can say this, and typically patients that have like high risk, non-muscle invasive bladder cancer.
That's me.
That's you. You're gonna beat the standard of care is to put you on BCG for up to 3 years.
This is my 3rd year.
Yeah, so you're close to being graduated, ideally.
Graduated at 86.
So yeah, it's never wrong to quit school. Don't worry.
Okay.
I think we have a question.
Yes.
Go ahead, Christine.
Hi, I don't have a question, but I do want to say that I'm thrilled to find out that there's a urologist in Ventura County that knows about bladder cancer. So that's why I logged in here. I'm a 14-year survivor of stage 3 bladder cancer, and I was treated at UCLA, and I had chemotherapy and a radical cystectomy. And I have that middle ground of an Indiana pouch. So what I wanted to put out there was, the gentleman was asking about the BCG shortage and things like that. Doctor, are you aware of the support platform for bladder cancer, BCAN, Bladder Cancer Advocacy Network?
I am familiar with it. It's what I typically refer to if I need to find like clinical trials, but is there a way to find places that have BCG on there?
Well, there's not necessarily places to find it, but I would highly recommend anybody facing bladder cancer or thinking about, family or anything, and you as well, doctor, that it's a great resource for everyone because it's filled with people from mostly the United States and Canada, but all over the world who have bladder cancer. And very successfully, there's a lot of people willing to help others. And so I remember a big conversation some time back about the shortage of BCG and how people were getting it and what was going on. So I would just encourage anybody it's a wonderful support group. It's online, and if you just Google BCAN, BCAN, you'll find it, and you can be anonymous or not. It's a very wonderful group specifically dedicated to bladder cancer. And I know when I had it, I actually was working with Cancer Support Community many, many years ago, and they had nobody that had bladder cancer. There was no support group there at all. And BCAN was just being organized when I was going through this, and I found them about 6 months after my surgery, and it was very, very helpful to me over many years, and I'm living the life, so you can't say. And I had stage 3, pardon me.
Thank you. I really appreciate it. It's nice to be at these kind of support groups too, because there's a lot of things I don't learn in medical school, to be honest, believe it or not. And one of those things is just where do I tell patients to get information or support? And that's something that I typically lean on patients to tell me where they're getting. So thank you.
Yeah. You can find out, if you're facing surgery or you have to make that decision of what kind of a diversion do you want, you can talk to numerous people who have had, any one of those diversions, and they'll talk to you directly. They'll contact you directly if you ask them to. about their experience and, how did they get through the surgery and whatever, everybody's experience is different, but it's definitely helpful. And then about life after, afterwards, how do we get through life and how do we thrive? So it's a wonderful resource for anybody facing this. Highly recommend it.
Thank you.
Thank you. Any other questions I can help answer?
Thank you for your time.
Thank you guys. Thanks for having me.
Picked up a
Thank
lot
you,
of-
cancer support community, for having this. Thank you very much.
Thank you all for joining us.
Thank you, doctor.
Once again, there is a survey in the chat, so make sure to fill that out, just so that way we can get feedback on how, we can, and the one in front of you is the same, there is one online, so if you can please take a few moments to fill that out. It takes about maybe 5 minutes. It really helps us out with, what we provide and
Absolutely.
how we can support you guys here.
Okay.
Thank you guys.
Thank you.
Thank you, and thank you, Doctor.
Are you going back to the office now?
No, I'm gonna hang